Hello, I am Flavio Ribichini, and I am very pleased to welcome you to this new PCR webinar dedicated to the new indications for the everyday practice to use drug-coating balloons. This is performed with the support of an unrestricted grant from Medtronic and is focused on very specific aims, which is review the newest indications for the use of DCB in daily practice, in difficult cases, in special situations like STEMI, bifurcations, CTO, small vessels, and calcified lesions. We will discuss about the rationale of using DCB and the potential advantages of this therapy over which is a conventional strategy using stents. And we will also analyze together the long-term angiographic and physiologic follow-up of specific cases. It's a pleasure to work with me today from Paris in the studios with three colleagues and friends, Professor Mattias Goldberg from Lund in Sweden. Okay, Sweden. Dr. Beatriz Vaquerizo from Hospital del Mar in Barcelona, in Spain, and connected remotely, Bharat Kyalani from Singapore. Thank you, Bharat, for being with us at this late time in the evening. So what we will do today is going through what is expected to be the future indications, or at least to investigate if there is room to use DCB in STEMI, in bifurcation lesions, in CTO, which makes really a lot of sense because of the need of extensive stenting in small vessels, which is probably the most tested indication in de novo vessels, and in a completely new and I would say unknown scenario that is the use of DCB without stenting or with addition of hybrid stenting in calcified vessels. So we will start reviewing the available evidence, and for this we have the pleasure of having here Professor Goldberg that will start with the serious part of the webinar.
Thank you so much. It's a pleasure to be here today. So it's a little bit challenging actually looking at the evidence in terms of DCB because the randomized studies are indeed smaller, often patients in the hundreds, which means that they're often underpowered for clinical events, which is something that matters to us as clinical cardiologists. So we turn to meta-analysis, and they mix different studies from different timelines using different DCB technologies. So the standard of clinical evidence is actually lower what we typically expect than if I have DES versus DS trials. So I'm going to read you a couple of the indications and evidence for using DCB today. It's in-stent restenosis. We make a division between smaller vessels and larger vessels, but also a little bit into the bifurcation and the side branch. Then, of course, we have the other indications that I'm not going to go through today too much, which are the clinical presentation and high bleeding risk patients. In terms of in-stent restenosis, there's a recent meta-analysis of 10 different randomized studies of almost 2,000 patients that showed overall, it seems like the MACE of DCB versus DES is similar. We actually did a recent analysis of in-stent restenosis from the Swedish SCAR registry, and we did a 5-year follow-up of almost 9,418 segments. It's a little bit more than 9,400 patients. What we also saw that the initial outcome was similar, but we had a higher TLR rate with DCB only. There was no difference in death or MI, and we also seemed to be, the patients were older than 80 years, also seemed to do a little bit better with DCBs versus DES. In terms of smaller vessels, a recent meta-analysis of 7 RCTs of 1,800 patients also showed similar TVR with DCB. And yet again, no difference in death or MI. In terms of larger vessels, a recent meta-analysis mixed RCTs and cohort studies and yielded almost 3,000 patients with a similar TLR with DCBs. And again, no difference in death or MI. And also seemed to be almost favoring the DCBs in this meta-analysis. In terms of bifurcation, we have a little bit more of a mixed image here. There's fewer patients, 1,200 patients, only 5 RCTs. Seems to yield similar TLR with DCBs, but I don't really explain why a lower MI rate, but no difference in MI, no difference in death. So this could be a power related, so I'm not sure if this is just a statistical anomaly or not yet. The largest RCT to date is the RECAGE-3-1 trial. It was a non-inferiority design trial. It involved 2,272 patients. The primary outcome was a device-oriented composite endpoint that consisted of cardiovascular death, target vessel myocardial infarction, and clinically and physiologically indicated TLR. It actually did not demonstrate non-inferiority with a DCB event rate of 6.4% versus a DS rate of 3.4%, which is very low. A subgroup analysis of the RECAGE-3-1 trial showed that there was some difference between the smaller vessels and the larger vessels. Seems as, at least in this study, DCB did better in the smaller vessels than it did in the larger vessels. So if I may summarize the evidence here, we definitely have a lower standard of clinical evidence compared to what we typically see in the DS studies. We are relying mostly on the meta-analysis of small and diverse RCTs of different technologies. But we do seem to have an overall similar clinical outcome, regardless if it's ISR, bifurcations, smaller or larger vessels. The caveat, of course, is that the largest RCT to date did not meet non-inferiority against DES.
Okay, so we have, let's say, some weak evidence and the largest randomized trial showing that non-inferiority was not met, but with this interesting signal that in small vessels, which is an accepted indication for DCB, actually there was no difference in favor of either DCBs or stents. So it seems that in that scenario, DCB are behaving quite well.
Yeah, and it's kind of weird because we said in the main analysis in large vessel, it seemed to be doing very well. Yeah. But in the RECAGE-3, the large vessels seem to do worse. So there's somewhat diverging signals here right now. Mm-hmm. And this is really why we need more data to support the use.
But we said that we are going to address specific points of interest to our community. And you have prepared a nice case that combines the two things, a STEMI case in a really bifurcation lesion.
Of course I have. So this is a case of a 62-year-old male. He has a STEMI, an anterior STEMI, which you can see on the ECG. The right corner looks good, but if you look in the LAD, mid-LAD, it's a bifurcation lesion. And it's really involving a large diagonal branch as well as the mid-LAD. So how do we treat this patient? So first, it was lesion prep with a semi-compliant balloon in the LAD, followed by a kissing balloon in the LAD and diagonal branch using 1-to-1 sizing. And this is the result after lesion prep. So it looks pretty good. And this is then followed by sequential inflation of drug-coated balloons in first diagonal branch, and then 1-to-1 sizing in the LAD with a 3/0/30 drug-coated balloon. And this is the end result as well. So it looks pretty good, I would say. Here it is in a different view as well. So this patient conducted a clinical and angiographic follow-up at 8 months. And this is where it's interesting, because if we measure the follow-up versus the post-PCI result, we can see that we actually do have positive remodeling in the mid-LAD. And when doing a measurement, we actually do see this both on physiological level as well as actually measuring the diameter. So we do have positive remodeling after STEMI in the bifurcation setting. So interesting, we did a study recently involving almost 1,500 patients. It was actually a study comparing PREVAIL with other DCBs in the Swedish SCAR registry, but it was also addressing it in bifurcation. And I think even though this is not a study of DCB versus DS, but if you look at the actual event rates, the target lesion revascularization rates are always very low, regardless if it's a DCB only, but also what we call the hybrid or the blended approach seems to be doing very well with an actual TLR rate of 1 year, which is below 2%, which I think is very good.
So thank you, Matthias. You have set the starting point. We start from relatively weak scientific evidence, but with very nice demonstration of a case performed with the 2 DCBs is actually a leave nothing behind attempt, because there is no hybrid combination, which seems to be the best way to treat bifurcation according to the SCART registry. And you were very precise, saying that you did vessel preparation in a kissing way with 2 balloons, but then you deliver the drug not simultaneously, but one at a time, first in the diagonal. Is that something that we recommend? Is that what you do?
Well, it has to do, there's actually 2 reasons for this. One of the reasons is that we don't want to deliver too much drug proximally. And the other thing is that we actually have a risk of oversizing. Since we actually leave nothing behind, we actually don't leave a stent behind. So if we do kissing balloon 1-to-1 sizing, we will actually probably overstretch the proximal carina a little bit.
Okay, that's a very good point. And at this point that we have started the discussion on real cases, I want to remind all those who are connected that you are virtually here with us. So I have an iPad here. You can send your questions, make your comments, and we will try as much as we can to address, taking the chance of these experts in the room. So I encourage you to do. We have a lot of hello, goodbye from Kenya, from Asia, from many countries, but now it's time for you to concentrate on the content of our webinar. And we will go now to the second part. And so I want to bring to your attention this publication that has been released very, very recently in Neurointervention. It's an expert review of how to use drug coating balloons in bifurcation. So this is very pertinent to what the case that we have seen. And the paper gives you very specific advices on how to deal with the non-stent possibility, with the hybrid one that we said might be the most commonly used, and how to go step by step from either the main to the secondary branch or vice versa. So I think this is important material you might review for the continuation of our webinar in the next 50 minutes. So we move now to the part 2, and we promise that we are going to address another difficult and very important scenario where probably we need to do better than just stenting. And so we have an expert. Actually, Beatriz Vaquerizo is the president of the Euro 4C community. Is an expert interventionist, and she likes CTO very much. So, Bea, please tell us why you might consider using DCB in CTO's interventions.
Thank you, Flavio. Why? Because traditionally we do full metal jacket for CTOs. We use a lot of stents, and we know that we have some situation in which drug-eluting stent performs suboptimally because we have the predictors of in-stent restenosis. And when you can see the predictors, you can see there are complex lesions like CTOs, and also the longer stent length is a predictor of restenosis, and we use traditionally a lot of stents when we treat CTOs. So also we know that long stenting is associated with increasing risk of TLR, but also a cardiac death increase rate. So why? Because maybe because we don't have enough data, maybe we use drug-eluting balloon instead of drug-eluting stent, we could improve the results. And also we could reduce the drug-eluting dual antiplatelet therapy in these high-risk bleeding patients. So we have few evidence. The first one study that was published last year was this retrospective propensity score matching that comparing drug-eluting balloon strategy, that means hybrid, combine drug-eluting stent and drug-eluting balloon versus drug-eluting stent only, and the endpoint was the MACE at 2 years. And you can see here that there was a significant reduction of stent number and overall length of the stent, 65 versus 42, and that was significant. And also was a highly significant reduction of the 2 years MACE, favoring to the hybrid approach. That means drug-eluting balloon and drug-eluting stent, and also drug-eluting balloon alone comparing to drug-eluting stent. Here also you can see this meta-analysis. These meta-analyses include 5 observational studies, and also you can see by the numbers that there is a clear tendency favorable to the drug-eluting balloon strategy. That means drug-coating balloon alone or combined with the drug-eluting stent, also in the novel lesions and in stent restenosis CTO. But it's true that there is a heterogeneity of studies. That means we need more data in this field to trust this. But what is our reality? In the EuroCTO experience, we are using more and more drug-eluting balloon. We use more combined with drug-eluting stent, but also we are starting using drug-eluting balloon alone in CTOs. And what are the main indications? Main indications are side branch, including in the CTO segment, and also diffuse disease in the distal segment behind the CTO. And we saw that when we use drug-eluting balloon or drug-eluting stent alone, we see a reduction of the number of the stents, and also we see a reduction of the stent length when you use drug-eluting balloon.
Before we go to the cases, I think these are very interesting data. There is an increment in the last 2 or 3 years of the use of DCB among CTO operators. There is an actual reduction of more than 10 millimeters of the stent length when you associate DCB to stent. And what is very, very important is that the use of DCB is more than double, and the reduction of the stent is significant. I mean, there are more cases treated with only 1 stent, less with 2, less with 3, and almost no cases with 4 stents. That used to be the common practice before. So in a certain way, the operators are trusting the therapy, like replacing the stents. You said this is in vessels when you find the bifurcations and in the distality, mainly in the distality, provided that you obtain a good vessel preparation. That's very interesting. Okay, and so now you have cases.
Yes, but I think the tendency is to use more and more drug-eluting balloons alone in the CTO, because also you are more in a safe, because if there is a reocclusion, there is not a STEMI in that patient because has collateral circulation. So we feel more comfortable to use more and more drug-eluting balloons in this setting. So,
and in the case you find a reocclusion, would you feel more comfortable to reopen the vessel if it was stented or without the stent?
Without the stent.
Without the stent, certainly.
Here is an example. This is the case that I use only drug-eluting balloon alone because the CTO was quite short, but you can see that there is a really diffuse disease in the right coronary artery. So we cross the CTO with a Gaia next to, and then I use IBUS for sizing, not for check the result. We can discuss this later. So according to the IBUS, I choose the non-compliant balloon or cutting balloon to prepare the plaque. And then I use 1-1 drug-eluting balloon inflate during at least 1 minute. So you can see the final results is quite well. There are not big dissections, flow limiting dissections. And we follow all the patients by CT scan. You can see here the CT scan and also the virtual FFR CT scan that was negative. And this is a more common case that is a combination of drug-eluting stent and drug-coated balloon for the distal disease. You can see right coronary artery was the long CTO. We cross with a wire, dedicated wire, and then according to the IBUS also we choose the balloons, the non-compliant balloons, and then we use the drug-eluting balloons for the distal. We use drug-eluting stent for the CTO segment and drug-eluting balloon for the distal segment. So we avoid 40 millimeters of stent in the distal part of the right coronary artery. So here you can see the result. The distal part is drug-eluting balloon and the proximal part is drug-eluting stent. And now you can see here the CT scan that you can see that the distal part is cut and also there is not interstitial stenosis. So in conclusion, I think we are using more and more drug-eluting balloons in CTOs. We have few evidence, but the evidence that we have is comparable and is positive, but we need future trials addressing these specific lesions. But I think we are using now with the objective to reduce the stents in this complex setting. Thank you.
Thank you, Bea. Very, very nice. So it follows a little bit what we said in the beginning. This is one of the settings where stents are not giving the best. I mean, we know, you show it very clearly, the longer the stented track, the higher the event rate. This is not only in CTO. Probably in CTO is more benign because, as you said, it's a previously occluded vessel, so a reocclusion might be less severe. But this has also been shown in other trials, like in Syntax. I mean, Syntax have demonstrated that each millimeter of stent increases the risk of having MI, death, and TVR. So it fits very well our question when we started the webinar, whether this might be one of the complex scenarios where the DCB might find an indication. Now, questions are starting to come. And of course, the first questions are addressed to the first presentation. Later, we will have questions on your recently given talk. And so the question number one is, how do you consider, if you consider in STEMI patients without stent using intravascular imaging and physiology? These are actually two different questions, but I address the two simultaneously.
That's actually really difficult and a good question as well, because we know that imaging, regardless of setting, as long as you have lesion complexity, we know that it reduces death, MI, and TLR. So of course, imaging is of use in itself. I think that for us, when we do apply a DCB, imaging is very useful because we know that we can do one-to-one sizing. That's really good both for vessel prep, but also application of the DCB. So we don't undersize or oversize the vessel and thereby reducing the risk of actually having to do valence stenting. So that's one thing. We don't typically use IVUS after we apply the DCB. There's a little bit of data saying they may shave off a little bit of the drug, but also because you are going to see some dissections. And it's actually quite difficult right now because we don't have any studies showing whether, a small dissection on IVUS how does that affect long-term outcome? So we typically use IVUS pre-PCI, and then we use angiography to assess whether we need to do any valence stenting based on dissections, etc. Physiology is also a little bit more difficult because post-PCI physiology, if you're using a wire, we always know that we're going to get a lower FFR or IFR if you do post-PCI physiology, because you are going to get a little bit of dissections. But we also know that physiology over time will actually improve. So we tend not to use post-PCI physiology if we're using a DCB approach. And we also use IVUS or OCT before we actually do the PCI. Okay,
so starting for physiology, I saw that in your case you use not wire-based, but angio-based physiology. And this gives you quite a good impression of the final result. But it was very interesting to see that the follow-up, there was an improvement, which correlates with the vessel enlargement, which is something that you will not expect after stenting.
No, of course, but yet again, we don't have any studies truly looking at this. So I think that moving forward, these will probably be sub-studies of the larger randomized studies. But right now, we don't know which threshold we're going to use for instance, QFR, whether we should do a valence stenting or not. We do know that there is potential for improvement over time as the vessel heals with the DCB.
Okay, so it's very good that you clarify that we don't have data and you have to wait for that, but we are very expert operators. So you said clearly you don't use wire-based, you rather prefer to do an assessment which is less expensive, less invasive, you don't have to recross the dissection with the angio-guided physiology. At the same time, you are not very convincing in the use of the utility of intravascular imaging. And Bea said very clearly, I use imaging to size the balloons and the material rather than to assess the final result. Is that true? So you don't need it to decide whether to stent or not to stent? It's just to...
No, I think it's not a question of needing. It's the question we don't have the data. I don't know what is a good result by intravascular imaging or by FFR when you use drug-eluting balloon. So because I don't have this data, I prefer not use a tool that I don't trust in this field. So it's totally different when we implant a stent. You need minimal stent area, but when you do drug-eluting balloon, because in the follow-up, you don't know how heal this vessel and the positive remodeling. So you cannot predict this by intravascular imaging at this moment.
So you don't have the parameters to aim at?
Yes.
So what you just check is at the baseline, when you have this diffusely diseased, totally occluded, the real lumen, because if I don't go wrong, you will size your DCB at a 1-to-1 diameter to the
And the
artery
most
ratio.
important is to prepare very well the vessel, because drug-eluting balloon is to elute the drug. So
Okay.
you need to prepare very well the vessel before.
Okay, you said elute the drug, and one of our colleagues asked, how long would you leave the drug-eluting balloon inflated to deliver the drug?
In CTOs, it's easy, because if you maintain more and more inflate the balloon, you deliver not more drug, but if you have a dissection, you seal this dissection. So in CTOs, you can inflate more than 45 minutes, but the minimum time is 45.
Minimum, yeah. I mean, it's advised to keep it.
But if
1
you have
minute.
a big dissection and you inflate more time, usually this dissection heals. So
That's a good advice. Keeping it longer at a lower pressure. It's an old way to reduce at least the angiographic aspect of the dissections. Very good. So questions are still coming. There is a very important one for you, which is, if we use DCB after an CTO, should we stay intraluminal, or can we stay also in parallel?
we don't have this information.
We don't know.
I have some personal experience that when you do a lot of dissections because reverse scars and all these things, I'm not sure that the drug is working very well in that situation.
Okay, that's a good answer. And there is another very interesting question, and I will address this. The colleague said, is there a risk of missing the therapy in the acute MI setting if we deliver the drug in a thrombus? So again, there is no science, there is no experience, but we have had in these webinars in previous sessions, Bruno Scheller, who is one of the most experts, and he said clearly, don't deliver the drug if the vessel has a lot of thrombus, because most of these drug will be in the thrombus and will wash out. So make sure of what we always say, it's a good vessel preparation in STEMI, is obtaining a good flow and a clean vessel before using the DCB. Hope we have addressed the most important questions we have received so far. And there is another very interesting that I will address to you, although it was referred to your case, but it's a very smart question. It says, in the case of the bifurcation, where you have a distal diameter being smaller than the proximal, but I think it's the same when we talk about CTOs, how can we decide which is the good balloon to use? Will you stay on the lower one or the smaller one or the bigger one?
It's a really good question. I use according to the distal, but sometimes if there is diffuse disease, I use two balloons.
That's the point.
One smaller for the distal and bigger for the proximal. But for a bifurcation, it's quite a tricky question.
Mm-hmm. Well, questions are coming like snowing now, although it's not winter. But before we give room to more questions, we move with the program, and to introduce the next part of our webinar, what I will show you is this document. This has been recently published in the European Heart Journal. It was led by Patrick Serrais. It's a drug coating balloon academic research consortium that is defining and standardizing many of the clinical and angiographic situations we are discussing. Indeed, the paper will give you a more precise definition of what is a small vessel, what is a large vessel, what is a large lumen enlargement or positive remodeling or recoil, what is diffuse disease, what are calcified lesions, chronic total occlusion, bifurcation, and high bleeding risk. So it's a scientific document that will be very helpful to all of you when you try to put together all this experience we are talking about with the lack of randomized trials, but with the evidence and the analysis that have been performed by these experts. This is to go through the next part, the third part of our webinar that will be presented by Bharat. It's dedicated to the use of drug-eluting balloons in diffuse and small vessels. Bharat.
Thank you very much, Professor Riviccini. So my brief was to really go through the role of drug-eluting balloons in diffuse coronary artery disease as well as in small vessels. So I just wanted to start off by saying, when do I use DCBs? Now, it's about 40% of my work these days. And in this part of the world, we use drug-coated balloons in a variety of situations: in in-stent restenosis, in de novo small vessels, in bifurcations, diffuse disease, patients with high bleeding risks, and those with diabetes. Now, we also are starting to use it more and more in acute coronary syndrome, as well as de novo large vessel disease. My colleague showed earlier some data about the role of drug-coated balloons in small vessel disease, and this meta-analysis kind of reinforces that. When you look at the 4 larger randomized controlled trials of drug-coated balloons in small vessel disease, there really was non-inferiority between this therapy and conventional drug-eluting stent therapy. And when we look at basket small 2 and the angiographic analysis and at follow-up, we really saw prevalence of minimal late luminal loss distribution, and this sort of persisted with time. Interestingly, when we looked at the thrombotic vessel occlusions that occurred, all of them occurred in patients with drug-eluting stents. Now, you would worry that it was a situation that would occur in those with drug-coated balloons, but this was not shown in this study. Now, what about the role of drug-coated balloons in diffuse disease? There is now emerging data for this therapy, and multiple registries, larger and larger in size, are starting to emerge looking at this therapy, suggesting it is a very viable solution for patients with diffuse coronary artery disease. I just wanted to show a case of this 52-year-old gentleman with hyperlipidemia who came into our center with acute chest pain. His ECG showed inferior MI, and he had primary PCI to his right coronary artery with a drug-eluting stent. His left coronary artery, however, demonstrated significant disease in the mid-LAD extending to the distal LAD, as well as the principal diagonal branch. Angiographic QFR was performed, and this demonstrated significant functional impairment in the LAD with a QFR of 0.70. He subsequently underwent PCI to his LAD and diagonal branches. Here you see the IVUS runs of both the LAD and the diagonal, demonstrating diffuse coronary artery disease, and we use IVUS to size our preparation balloons as well as our drug-coated balloons of choice. This was the result after vessel preparation. We tend to prepare our vessels with both compliant as well as cutting or scoring balloons, and really we demonstrated good luminal gain with no flow-limiting dissection. Now you can see a significant bridge in the mid-LAD, and this was one of the reasons why we decided to avoid implantation of a scaffold, and hence we proceeded with drug-coated balloon angioplasty. The final result was very reassuring, and the QFR was re-performed, and this demonstrated an improvement to 0.92. An IVUS post-DCB, more for research purposes, demonstrated visible residue lining the vessel, which could be related to a coating of paclitaxel sitting on the luminal wall. So in summary, he had treatment with a metal-free PCI strategy using 3 drug-coated balloons, 2 in the LAD and 1 in the diagonal branch. A relook at 9 months demonstrated patency of both the LAD and diagonal vessels with good TIMI3 flow. Repeat functional assessment demonstrated a QFR of 0.93, which was very reassuring. Now, this demonstrated the local effect of late luminal enlargement that paclitaxel induces in coronary arteries after balloon angioplasty. This is a feature of Glagoff phenomenon in which paclitaxel causes late luminal enlargement and positive remodeling, due to a compensatory increase in the local vessel size. So in summary, DCB angioplasty offers a scaffold-free treatment option for small vessels and diffuse multi-vessel disease. It simplifies complex PCI, and positive remodeling and late luminal enlargement is a benefit that we see in paclitaxel-based DCBs. Thank you very much.
Oh, thank you. Thank you for sharing this nice case. I think we have many comments to do, and many questions will be arriving in this different setting of small vessels and diffuse disease. So I will start making an observation that probably was not really evident during the presentation. This patient had a clear intramyocardial breach. And we know that stenting a myocardial breach is not recommended. So I think apart from the diffuse disease, the small diameter of the diagonal, the bifurcation itself, that are all good indications to try to avoid or reduce the number of metallic stents. The issue of having this dynamic obstruction, was that considered as one of the characteristics of the patients that were favoring DCB rather than stenting?
Absolutely. We know that putting a scaffold in an area of bridging does increase the risk of stent fracture and stent failure down the track. So it definitely came into our consideration, and it was one of the reasons why we decided to pursue the drug-coated balloon approach.
Okay. This is a question to the three of you. It has probably nothing to do with the DCB, but you will see it at the end. Has it ever happened to you, Bea, that not you because of your expertise, but some others less expert operators have put a stent on a myocardial breach and the breach moves farther distally or proximal to the stent and you have to run after these spasms?
It doesn't happen, but I implant stents in that kind of breach in STEMI patients, and always I try to follow the patients, and not always the result is good.
Mm-hmm. Have you seen this spasm moving distally or proximally to the stent?
Thankfully, many years ago, we really try to avoid doing stenting in myocardial bridges. So this is really one of the settings where I think DCBs should be a first-line therapy.
Yeah, so avoiding the stent, and of course, insisting with medical therapy, mainly based on beta blockers, and ideally avoiding also the nitrates, which creates a bigger discrepancy. So this was a very interesting aspect of your case, but I was also very puzzled by this interesting image that you showed after the DCB treatment with paclitaxel at this wide ring in the intima of the vessel. Can you explain what does it mean? If this remains there forever, if you had the chance to control at the long term an image like this, if it's still there or disappears, and what it means?
Yeah, that's a very good question. We don't normally do imaging post DCB angioplasty, but sometimes we do for research purposes. And in this situation, we did see this ring of residue, which sometimes we do see in particular brands of DCB, mostly because of the excipients that the paclitaxel is mixed with, and it tends to hang around on the luminal wall, and it's visible on an intracoronary imaging, whether it's IVUS or OCT. It tends not to persist. It tends to dissolve away over time, and usually by the time we do another imaging run or down the track, we don't tend to see it any further. So it's probably an incidental finding, and but it is suggestive that the drug is on the vessel wall and transfer is happening. So that's maybe a good sign.
Mm-hmm. Thank you. Very interesting. So I have to tell you that there are many questions, and we want to give a room to that, because it's very nice to see that there is a proactive participation. Many of the questions are a little bit repetitive, but I see a lot of interest And this will go, I will address to you, Matthias, and also to you, Bharat, on the steps on how to treat a bifurcation. Many colleagues are asking whether you should do the kissing balloon. If you do the balloon preparation, then you stent the side and or the main, and you delay the side, and then you do the drug coating. Or if you do drug coating and after that you decide whether the stent is needed. I mentioned this previous paper. All what you're asking is probably described, but I want to hear your experience and Bharat's experience. Matthias.
Trying to be the scientist here, we don't actually have any solid evidence to say which one to use. But from a pragmatic and practical view, we tend to use kissing balloon to start off with, and then we apply the drug-coated balloon to the side branch, followed by main branch stenting, because sometimes there is a risk of interaction between the DCB and the stent struts when you try to enter into the side branch. So we do try to avoid touching the side branch after we've done main branch stenting.
Good. Bharat, do you have any tips and tricks to comment and share with us?
Yeah, very, very similar to Matthias. I tend to work on the side branch first, do drug-coated balloon to the side branch, and then proceed on with a provisional approach with the stent, or even a drug-coated balloon if preparation is suitable. So once you sort of have delivered the drug-coated balloon in the side branch, I too try to avoid further instrumentation if I can avoid it. So a very similar approach.
Okay. Regarding the use of different guiding catheter extensions and wires, Bea, they ask if there is some contraindication to use one specific device like this, like extension catheter, guiding catheters, with the use of DCB.
We don't know, but there are some balloons that they protect the drug. So, but in general, I think all the new generations of drug-eluting balloon are really protecting the drug, so you can go distally and you don't lose the drug during the way. So I don't think there is any contraindication.
Absolutely. Matthias, this is for you. A colleague says, if I have prepared the vessel and I have decided to go with DCB, and then there is a part that I want to stent, the stent will drop, will fall in a dissected part of the vessel. Is that a concern, or is that something you can do easily, or you advise to stent everything?
That's a truly great question, and we don't know. I think that if I would need to do bailout stenting, I would want to try to follow the rule of trying to stent healthy to healthy. Because when we're applying the DCB, what we kind of do is that we would just want to treat the lesion. We understand we don't have to treat everything, but the landing zones of the stent, we know that if we land in a heavily diseased segment, that increases the risk of MACE over time. So, I would actually go back to the evidence we have in terms of IUS and using DS, and I'd try to cover it healthy to healthy.
Okay, maybe I don't agree exactly with that. I think that one of the next questions that I like very much is indeed, when do we need to stent a dissection? So this is by far the most difficult question because there is no real answer. This is an answer that comes out with experience, but I would like to remember you that this is the second webinar of a series dedicated to DCB. And the first one we did, I think it was in March or April, was exactly dedicated to this point. And it was called Dissections, Stent or Leave It. So to those asking this question, I recommend to go back a couple of months ago and see this webinar that was, I think, very, very interesting because we addressed exactly when to stent or not to stent. There is another very practical question, and this will go to you, Bea. Dual antiplatelet therapy. We said that DCBs are very appealing in high bleeding risk patients. That's very clear. But in case you have a stable patient, how long would you keep this patient on dual antiplatelet therapy without stent, just DCB?
In our center, we have this discussion because the trials are not really clear. They recommend in the randomized trials in small vessels at least 3 months of dual antiplatelet therapy, 1 month, sorry. So in a stable patient, maybe 1 month is enough but I know that several centers in Spain in high-risk bleeding patients, they leave only aspirin 3 months. So now we are in this variety of strategies because there is not a real consensus in that part.
Good. And in case the patient is presenting with acute coronary syndromes, would you, and he is high bleeding risk, would you consider reducing the length of the DAPT because there is no stent?
I would. I think it comes down to, we know that there's a risk of stent thrombosis if you put in a DES, of course. And if we do DCB, we know we can reduce that. Of course, the non-culprit lesions, we won't protect them with the dual lateral plate therapy if we reduce the time we have that. But for the lesion in itself, if you have bleeding risk patients, we will of course reduce it. Maybe up to, a month is what we have in our clinical practice right now.
Absolutely, especially in small vessels that are at higher risk of occlusion and after stenting. So we move to the fourth and last clinical, or better, angiographic scenarios. And I will again recommend you this paper, which is similar to the previous one. It's an expert document that was published in the JACC. So if you don't have access to one of the other journals, this is again addressing what we are going to discuss now, which is another critical angiographic scenario, which is the treatment of calcified lesions. Look at this CT scan. On the right, you see the LAD at diagonal. On the left part of the image, you see the right coronary artery. And this is a massive calcification of a 65-year-old male with stable angina. So he underwent the CT scan to understand if it was a coronary artery disease. And it's clearly showing 3-vessel disease. You see now in the diaphragmatic part, you see the posterior descendant of the right coronary artery, which is also severely calcified. This is confirmed by the angiography. It's a dominant right, and we will see there is a tight stenosis in the distal part of the PDA that normally we don't treat, especially because you will see in the next angiographic image that the left system is already providing collaterals to this right. What we can understand from this angiography is that the circumflex has a tight and long stenosis which looks moderately calcified with angiography, while the LAD is totally occluded and it's heavily calcified. And you see that through the septals is providing collaterals to the PDA. So this is a typical 3-vessel disease with the CTO. We try to open the CTO. In case of failure, this was certainly to be considered for surgery, but it was not a difficult CTO to open, but balloons did not cross. So what we did is, of course, using our good old rotational atherectomy device to open the vessel and then put a balloon. And you can see on the right side of the slide that the balloon is not inflating properly. So what we did was IVUS to understand what is happening, and it's clear. It's a 360 circumferential calcifications with reverberations, which mean it's deep calcium, and there are no evident fractures. So we upgraded our treatment to the shockwave, which is very effective in these plaques to create the fractures. You see how easily it dilates, it opens, and when you repeat the IVUS, you can see that we have an adequate gain of the minimum lumen area with fractures everywhere, and the angiographic image after the vessel preparation is good. So we decided to avoid stenting just to test this hypothesis of using DCB in these difficult patients. And so we have a 3.5 20 and a 3.5 30 millimeters paclitaxel eluting balloons with this final result. With an acceptable physiology, remember it was a totally occluded, so physiology will take a while to normalize, but was above 0.80, so probably not ischemia inducing. And then we address the left circumflex. So it's a balloon preparation with a non-compliant 2.5, followed by an IVL 2.5, and then with this nice angiographic vessel preparation, we deliver paclitaxel from a 3 millimeters, 30 millimeters long DCB. And again, the immediate result looks good, But the most interesting thing we want to share with you is the follow-up at 6 months. So you can see that both vessels, the CIRC and the LAD, which was totally occluded, are widely open with normal flow. And it's interesting to compare the baseline totally occluded, the immediately after DCB with the physiology that we said it's 0.85 QFR, and a clear positive remodeling with a net lumen gain and on the right side of the slide, and a significant drop upwards of the physiology with a QFR that reaches 0.92. So this is, I think, an exclusive characteristic of an uncaged vessel, because there is no stent, so the vessel, despite being calcified, can enlarge. And as a consequence, the physiology is better if there is no restenosis. I have seen already that there are many questions on this point, and we will leave it for the last part of this case. Same thing, we observe the same thing from the baseline to the immediately after, which looks actually less good than the follow-up. The follow-up shows a clear vessel enlargement with, again, an increment in physiology from 89 to 97, so it's practically normalized. So this case is, of course, one case. It's not a randomized trial. It's not the science we're willing to have, but it tells you that in severely calcified lesions after optimal lesion preparation, DCBs might induce positive remodeling despite the fibrotic and calcified composition of the vessel wall. This yet not explored strategy in trials may imply some important considerations. Enlargement of this diffusely atherosclerotic wall with better physiology, avoiding the risk of undersizing or under-expanding a stent if the vessel preparation was not adequate. Of course, you spare the side branches because there are no struts in between the main and the side vessels. No stented vessels are easier to be retreated in case of need. In case of re-PCI, as Bea said, she prefers to reopen a totally occluded vessel without stent rather than with the long stent, or even in cases of need for surgical revascularization in the LAD. And last but not least, we have just said it, the short-term dual antiplatelet therapy, it's a very important characteristic of this kind of treatment because this patient has no metallic stent. So again, this is a case, but it's a proof of demonstration of something that never happens after stenting, which is getting a bigger vessel. And so I will jump on the questions that have been already sent on this specific issue. But there is still one very important. One colleague asked, ESC guidelines recommend direct stenting for STEMI. How is that you use DCB in this patient? Do you want to make a brief comment on that? Or in direct stenting in general, I would say.
Well, I rarely do direct stenting. I truly do, because we do IVUS guidance these days. We use imaging guidance for the vast majority of our PCIs, especially STEMI, because we know so many of these STEMIs actually have underexpanded stents, which may actually prove to be a benefit when we're using DCBs in that specific setting. Now, I want to be a little bit careful, because if we do have a thrombus, we actually may not get a drug delivery if we have a DCB in the thrombus. So I think that I'd be very careful overall using direct stenting, but also if we are using DCBs in the STEMI setting, we need to make sure that we don't have a lot of thrombus.
Yeah, we said that before. In general, I think that, first of all, in calcified lesions, you should never go with direct stent. In STEMI, either, because in STEMI, the vessel that you see angiographically in the acute ST elevation MI is always smaller than what it really is, because there is a spasm, there is low flow, and there is thrombus. So even in STEMI, we recommend to do a good opening, obtaining a good flow. And guess what? Many times the flow gets worse after stenting. So this is one of the rationales of avoiding stenting in STEMI, because the metal will crash and squeeze the thrombus and will create microvascular obstruction. So there is a huge rationale in avoiding stenting. I think that direct stenting was the results of the extreme enthusiasm of the low restenosis rate initially observed after drug-eluting stent, but today I think it's not recommended unless it's really a very fancy PCI that you can do very easily. But lesion preparation is emerging as the most important step for any kind of devices, be it stent, be it scaffolds, be it drug-eluting stent, or even only balloon PCI. So I hope this was a satisfactory answer to this colleague, because it was an important question. Now we go to the setting of calcium. The good question here is, how do you know, are you concerned about the reliability of the drug transfer in a calcified plaque? This is a very important question, and I would answer saying that if you don't see fractures in the plaque, if the plaque is still a thick cap with deep calcium and you did not create fractures, the drug will not get into the media, and this is the target. Ideally, it should not arrive to the adventitia, but we should stay at least in the intima. So if you do intravascular imaging and you don't see the fractures, and your MLD is not well prepared, this is not a vessel for DCB. You might try it harder and then eventually go with a stent. What do you think about that?
I totally agree, and I think it comes down to like thresholds for vessel preparation. And we do know that if you have more than 30% of residual lesion severity, you actually do need to do more vessel prep. But this is why we need imaging. We need to use more cutting or scoring balloons in this specific setting in order to actually be able to get a good result from a DCB.
Mm-hmm. Well, another interesting question. Do we use scoring or cutting balloons for vessel preparation? Does this make a difference, or you think it's an addition that does not make a difference?
We don't know the data, but clinically, in the daily practice, we see totally difference. Mm-hmm. We are a center that we use a lot of cutting balloon, and now we change a short cutting balloon, longer cutting balloon, because we prefer that for plaque preparation. And we try 1-1, but undersize the low pressure. Mm-hmm. And Good. We see the difference because we don't see dissections. And I think that the drug maybe theoretically goes better to the media.
Good. Bharat, which is your experience using scoring or cutting for lesion preparation before DCB? Does it help?
Yeah, it's a very similar base experience. We find that both the scoring and the cutting, we tend to get more controlled dissections and better luminal gain. Again, there isn't much data out there, so it's all anecdotal evidence. But in our practice, we tend to use a lot of scoring or cutting balloons before DCB angioplasty.
Mm-hmm. I will share an experience that I learned from Bruno Scheller, and I am really trying now in my cases. And he told me, you know, when an angiographic dissection looks a little bit ugly and you are just about to open your stent, before doing that, use either a scoring or a cutting balloon, because this will create some kind of cut and will transform this dissection from a parachute to the strips, and the flow will become better. I think it makes a lot of sense. I have tried a couple of times, and I can tell you that probably the use of cutting or scoring may be not only limited to vessel preparation, but also to the management of these dissections before we decide to leave it or to stent it, which is the real question. Okay. So I would love to have more time to share with you because you are such an active group making more and more questions. There are some important ones that I would like to go, but probably we don't have time. Let me see if there is a... yes, scoring, balloons, CTOs, yes, calcified, very short one. This, of course... we know that not all DCBs are the same. There is a colleague saying, I have tried, it does not go like a stent. Is that true?
It depends of the drug-eluting balloon.
They are not
I think, but new generations are improving a lot. We compare the first generations and the current generation is totally different.
Do you have the same experience?
I have STEM experience, but I still think that there's room for improvement. I still think that it bugs me if I have issues delivering a DCB after doing good vessel prep, which sometimes happens.
But would you agree that delivering a DCB distal is more difficult than a good stent? Still?
Still sometimes, yes.
Yeah, I think we all agree. But your opinion?
Yeah, exactly. I think it just, depends on the drug-coated balloon you're using, but particularly if it's longer, it tends to be a bit harder than some of the third-generation stents that we're used to.
This is another indication for excellent optimized vessel preparation. We have to go to the conclusions. We have agreed on the fact that we are assisting to a rapid and wider adoption of DCB in many complex settings. We have gone through that, but supporting by a strong rationale, but by weak evidence. So this evidence, do we still need to perform long randomized trials before saying the last word?
I think it's an easy conclusion. Yes, we do need large randomized clinical trials evaluating DCBs versus DES in different clinical settings to make sure that they're similar in outcome.
Good, I absolutely agree. But Bea, we used to say in Spanish, no lo veo, no lo creo. So we need to see the long-term results to believe that the result we left, which is never stent-like, will be better than the immediate. Do you think that these trials should include angiographic follow-up, like at the times of DES, or no?
I think so, because also we have a positive remodeling, so we need to check this layer lumen loss. So I think so.
Yeah, I think this will convince many operators to trust the therapy. And the last question, in Asia, you are well ahead in the use and the application of this technology. But do you find an indication or a rationale for combining DCB and bioabsorbable scaffolds?
Yeah, definitely a very interesting proposal. And I think there are some operators here that have started to go down their path of using bioabsorbable scaffolds together with drug-coated stents so that you eventually leave nothing behind. So a very interesting space.
This would certainly reduce the fear of leaving dissections and suboptimal vessel preparation. So the marriage in between the two might be very interesting, but of course requires adequate research. So we finished, but before leaving you go, I want to share with you a very good news. It's the first European meeting of the Euro 4C community in Madrid by the end of February next year. You know, Euro 4C, it's a PCR group dedicated to the treatment of calcified and complex patients. It's the first European meeting. We absolutely will address all what we have gone through, and obviously there will be room also for drug-eluting balloons and circulatory support, intravascular imaging, lots of hands-on and live cases. We'd love to have you there, so we invite you officially to participate. And with this, I have to thank you, Matthias, Marat, and Bea, for having shared your knowledge, your time, your experience. And to all of you who participated, I apologize for not addressing all the questions, but we will do better the next time. Have a good evening.